Good morning. I would like to thank the organizing committee for inviting me to be part of this prestigious meeting. A special thanks to my colleague, friend, Professor Amal for including me all through the years in her meetings. Thank you, Amal. This is a Bristol-Myers Squibb Symposium, and the topic is beta thalassemia, unmet needs, and complications. This is my disclosure. The outline of the presentation, I'll start with a general overview of thalassemia. How do we understand the disease today? Then some unmet needs in thalassemia, mostly transfusion and chelation, and then an overview and management of specific complications that we see in adults thalassemics. As you know, thalassemia is becoming an evolving global problem worldwide, and this is mainly due to migration. The predominance in the low or middle income countries stretching from sub-Saharan Africa through the Mediterranean region and the Middle East to South and Southeast Asia has now moved completely due to recent population migration. We see a lot of these patients in Europe and USA. What I want to highlight here before moving into the presentation is how do we view the disease today? And we view the disease today depending on transfusion. So the transfusion requirement is commonly used to distinguish the phenotypes of our patients. At one end of this arrow, you would see those patients that are called TDT or transfusion-dependent thalassemia, and this group of patients that require regular lifelong transfusion for survival. This is beta thalassemia major, severe hemoglobin E beta, and hemoglobin BARTs. And at the end of this arrow, you would see the trait, thalassemia trait. And in between, you will see a very interesting group, which we call the non-transfusion dependent thalassemia, where we used to call them thalassemia intermedia. And this includes beta thalassemia intermedia, mild to moderate hemoglobin E beta, and hemoglobin H disease. This is a group of patients that do not require regular blood transfusion for survival, but they might require blood transfusion intermittently for poor growth development, for specific morbidities, and occasionally for surgery, pregnancy, and infection. And sometimes they do not require blood transfusion at all. So all through these presentations, you will hear the term TDT versus NTDT. This shows you some of the complications between TDT and NTDT. And this has been a work that I have done with Professor Capellini years ago, where we showed that in NTDT, the morbidities are completely different from TDT. Now let's concentrate a little bit about the pathophysiology of thalassemia. This is really very important because it allowed more efficient management and novel drug development if we understand better this. So it all starts with an imbalance of alpha to the beta, leading to what we call ineffective erythropoiesis. This is a key hallmark of what we will be showing and talking about, and at the end in different presentations also when we talk about luspatercept and targeting ineffective erythropoiesis. So the imbalance between alpha and beta would lead to ineffective erythropoiesis, which in turn would lead to hemolysis. As a result, this would lead to anemia and iron overload, either due to primary absorption or secondary blood transfusion. So the three main components are ineffective erythropoiesis, anemia, and iron overload that would lead to all the complications of thalassemia. So targeting ineffective erythropoiesis will decrease all these complications. So tailored transfusion and iron chelation in TDT and NTDT and the development of novel therapies targeting the pathophysiological mechanism is all secondary to our better understanding of the disease. This is from a recent publication that we have published in New England Journal of Medicine a few months ago. It shows that significant advances in the last 2 decades in understanding risk factors and the role of conventional therapy in driving or ameliorating the complications. So the imbalance would lead to ineffective erythropoiesis, and ineffective erythropoiesis would lead to hemolysis and anemia, leading to hypercoagulability, as I discussed. Also at the same time leading to primary iron overload. So all of these will interact together, leading to most of the complications that we would see in thalassemia. And this is also from the New England Journal of Medicine, showing you all the complications that are a result of ineffective erythropoiesis, anemia, and iron overload. So that was a very brief introduction on thalassemia and the modern way of looking into the disease. Let me discuss a little bit about the unmet needs in thalassemia. Transfusion and iron chelation patients with TDT. So this is the first part that I will discuss. As I said, alpha to beta chain imbalance leading to ineffective erythropoiesis, hemolysis, hypercoagulability, anemia, and primary iron overload. In TDT, in order to decrease the ineffective erythropoiesis, transfusion is given so that these patients will not anymore be anemic. So as you see in the blue line or the green line, transfusion will ameliorate ineffective erythropoiesis and decrease anemia. This is a study, an early study in the 95, but it shows you the relation between transfusion regimen and suppression of erythropoiesis. If you transfuse these patients, you will suppress ineffective erythropoiesis, and as a result, you will decrease the anemia and decrease some of the complications. The introduction of transfusion improved survival in TDT patients. This is very well known study, although it's an old study, but we all know that if these patients left untreated, patients would die within few years of birth. So the introduction of regular, safe blood transfusion increased the survival of our patients. And the standard transfusion regimen in TDT is every 2 to 5 weeks, keeping a prehemoglobin level of 9, 10.5. Sometimes we increase it more if we need to suppress more the bone marrow. Post-transfusion would be around 14, and we monitor occasionally these patients. But transfusion comes with, it doesn't come free. It comes with a lot of adverse events. And some of the most adverse events are infection, alloimmunization, and I highlighted iron overload. Some of the less common side effects are acute, febrile, hemolytic, non-hemolytic, allergic, TRALI, delayed alloimmune, hemolytic, extravascular, graft versus transfusion, graft versus host disease. So transfusions do not come without their own adverse event. And one of the most important adverse events is iron overload. So once again, looking into our famous pathophysiology diagram, showing that transfusion will lead, as you see in the red line, although it ameliorates ineffective erythropoiesis and anemia, but it will worsen iron overload. And we all know iron will enter the body, it will saturate transferrin. As a result, we will have some free transferrin, what we call some free iron, what we call non-transferrin bound iron, which will penetrate into all these organs and lead to all the complications that we know. Heart complications, heart failure, arrhythmia, liver complications, cirrhosis, hepatocellular carcinoma, and endocrine complications, whether in the pituitary, thyroid, parathyroid, gonads, and bone and the pancreas. And we also know by now that the introduction of MRI years ago have allowed quantification of iron concentration in target organs, specifically in the liver and the heart, measuring them by R2 MRI or T2 star MRI. And this has been validated very well against all markers, and it is now the current practice for patients with thalassemia to measure iron overload. We know that there are some thresholds also, an LIC more than 7, increased morbidity and liver disease, more than 15, increased hepatic fibrosis, cirrhosis, and hepatocellular carcinoma, and also it's associated with cardiac disease. A T2 star more than 20 is normal, less than 20, increased risk of arrhythmia, less than 10, not only arrhythmias, but heart failure and death. So by now, we have very important thresholds to follow up on our patients. It is important here to state that the LIC thresholds should be revisited, hopefully soon, because I do believe that they should be lower than the older studies that have been done. And Because of the blood transfusion and chelation, these patients need to be followed up regularly. This is from the old guidelines. However, it's worth mentioning here that the TDT TIF guideline have been published recently, and they are available online for everyone to follow them. Now, since we're talking about modern therapies, it is really, or diagnostic modalities, it's really very important always, and I like to tailor all what I say to the need of resource-limited settings. So this is a paper that I have done with Vipracacid from Thailand, saying, what about if our patients do not have MRI or limited MRI availability? So there are three scenarios. Patients above the age of 10, MRI is available, so one could do the liver and the heart for the patient and follow them. If they are not available, the patient should, or the physician should depend on a serial serum ferritin every 3 months and look into a trend and adjust the chelation for the patients. If it is of limited availability, then we should do it probably for patients who are between the age of 10 and 18, serum ferritin more than 2,500. Any patients with a serum ferritin more than 2,500 should be evaluated. Patients with an increasing serum ferritin trend, and I think each country should set certain criteria for their patients if it is in areas with limited MRI availability. With time, as you know, we had evolution of chelation therapy, so now we have a lot of chelators available. Desferoxamine with all the issues of subcutaneous, intravenous, problems of adherence, then diferiprone, then Deferazerox, the dispersible tablet with some of the GI disturbances. Then recently we have the JNU or the Deferazerox, tablets, which reduces the adverse events, and it is very easy for the patients to use. And we all know that with the introduction of iron chelation therapy, the survival of TDT patient improved, similar to the introduction of blood transfusion. So both anemia and iron overload that are secondary to ineffective erythropoiesis, the survival improved with good chelation and safe and good transfusion. With the introduction of an MRI, I have already discussed, the morbidities have changed completely to different types of morbidities that we are seeing in our patients. So trends of mortality from Greece, Cyprus, and Thailand shows, for example, in Cyprus, survival to the age of 30 years increased by 8% in the period of 2000 to 2018 as compared to the period of 1980 to 1988. In Thailand, only 20% of patients with beta thalassemia major reached their fourth decade of life, mainly because they received inadequate blood transfusion and iron chelation. So I'm highlighting more and more the unmet need of transfusion and chelation. Now, we still have persistent challenges with transfusion and iron chelation therapy in TDT. Continued challenges with transfusion and iron chelation and added burden to treatment, limited access, suboptimal use, cost, resource utilization, convenience, adherence, lack of efficacy, adverse events. These are all continued challenges with transfusion and iron chelation and of added burden to the treatment. This is why we need more treatments to decrease these challenges and improve the quality of life as well as survival and less morbidities in our patients. There are a lot of regional variation in transfusion practices in TDT, and this is from one of the papers that we have worked on with the VIP, also showing you that all through the transfusion practices differs in the different areas. Also, transfused patients had significantly more all-cause HCUR and iron chelation therapy compared to non-transfused patients during follow-up. Thalassemia-related and a risk of liver, endocrine, cardiac, and renal complications were significantly and positively correlated with increase of red blood cell transfusion. So this is really very important. If you look at the healthcare resources of the country and compare hospital admission, hospital days, outpatient visits, emergency room, whether to transfuse average 12-week all-cause over followed-up period or average 12-week thalassemia-related healthcare resources over the follow-up period. Iron overload remains to be a concern in most parts of the world despite iron chelation therapy. There are a lot of barriers, as I have discussed. Early iron overload is asymptomatic. Administration of chelation therapy may be inconvenient. Chelation therapy has side effects, transition from childhood to adolescent, and patient does not feel improvement. So these are some of the important papers over the last few years, and this shows you the 2021 TIF guidelines. Our patients are getting older, and I will discuss with you now some of the morbidities that happens in an adult patient. So the last part of the presentation is an overview and management of specific complications in thalassemia. Let me start with malignancy. As we know, malignancy is an emerging concern in adult patients with thalassemia. It could be solid tumor malignancies like hepatocellular carcinoma, renal cell carcinoma, papillary carcinoma of the thyroid, or lymphoma in the hematological malignancy. We have two important papers, one from Iran and one from Taiwan, and in both studies it shows that thalassemia are at a higher risk of cancer. The solid malignancies is mostly due to iron overload and seen in papillary, thyroid, hepatocellular, and renal cell carcinoma. This is an overview that I have done with one of my fellows that shows you that the majority of the complications in solid tumor is hepatocellular carcinoma, but still we have thyroid, breast cancer, and renal cell carcinoma. While in the hematological malignancy, due to overstimulation of the bone marrow and sometimes due to transfusion and splenectomy and viral infection, these patients get more hematological malignancies. And in this review, you'd see that it is mostly lymphoma, leukemia, and some cases of multiple myeloma. So the possible mechanisms for hematological malignancies versus solid tumor, which is iron overload, here it's mostly stimulation of the bone marrow, hydroxyurea use, viral infections, sometimes blood transfusion, and iron overload. So iron overload aggravates genomic instability, leads to immune regulatory imbalance, promote cancer development, oncogene virus, and abnormalities involving the immune system. Hydroxyurea also might play a role in the causing malignancy. Therefore, it's very important to always survey our patients for hepatocellular carcinoma. Caution should be used for in hormonal therapy. New antiviral therapies should be introduced and given to treat hepatitis C. Once again, the role of chelation therapy is really very important and the stakeholder in treating our patients. Another complications which we are seeing more and more is hypercoagulability and vascular disease in NTDT. The main problem is the pathological red blood cell. However, splenectomy, iron overload, no transfusion will all lead to transfusion. The main important mechanism is the pathological red blood cell. In a study, epidemiological study that we have done years ago on 8,860 patients, we showed that thalassemia intermedia is at a higher risk of thrombosis compared to the thalassemia major. And the optimal care study, which was published in Blood in 2010, the most cited paper or manuscript on NTDT, where it included around 584 patients. It shows that in NTDT, complications are different from TDT, and thrombosis is a major complication. And those patients that are splenectomized with high nucleated red blood cell, meaning high ineffective erythropoiesis, once again highlighting the importance of ineffective erythropoiesis, high platelet count, are all at a higher risk of thrombosis. This is why it's very important to have a consult for an adult hematologist to deal with patients who are at a higher risk of thrombosis. Aspirin therapy, we can keep this till question and answer. Transfusion, anticoagulant, and anti-aggregate. Chelating the patient is really very important. We have developed recently a score together with Dr. Capellini and Dr. Msallam, where splenectomy has the highest score for these patients to get more thrombosis. I would like to highlight also renal dysfunction, which is becoming a very important issue in our patients. The renal disease in beta thalassemia is due to iron overload, chronic hypoxia, iron chelation, and this will affect the glomerular filtration rate as well as the tubular cells. We have shown some time ago, and others have shown, that adults with TDT show a slow but progressive decline in their renal function. Chronic anemia would lead to the damage. Iron overload would lead to the damage. Overchelating your patients would lead to damage. So it is very important to transfuse them well and chelate them well. In a study that I have done here in Lebanon, we have shown that renal dysfunction is evident in the anti-DT patients that are never transfused and never chelated. And this is associated, as you see, in the upper curve by LIC and the other one by NTBI. So renal dysfunction can progress to end-stage renal disease. And this is from a group of our patients that ended with on dialysis. And one should always keep in mind these complications in their patients. The last complication that I would like to highlight is the pulmonary hypertension. It is more common in anti-DT than TDT. But when we talk about anti-DT and TDT, we mean here by a TDT who is very well transfused and chelated, unlike a large number of the TDTs in our part of the world. So sometimes they behave like anti-DT and they get pulmonary hypertension. And splenectomized patient never transfused with high nucleated red blood cell, iron overload are at a higher risk of getting pulmonary hypertension. These are two studies, one done in Lebanon showed that pulmonary hypertension is associated with an increase in LIC. And the other one is from the Webthal group from Italy that shows you clearly that splenectomy is a bad marker in producing pulmonary hypertension, and age also is another marker. This is from one of the papers that we have published in Blood. I will not go through the details, but it lets you risk assess your patient. If they have a high TRV, you should do a right heart cath. If they have a low TRV, not symptomatic, monitor them. If they are symptomatic, you can do a right heart cath. So at the end, I would like to say that beta thalassemia is a disease of multiple risk factors and multiple morbidities, which logically implies the need of multidisciplinary management. This becomes particularly essential in older patients where I have described a lot of the morbidities. The ideal treatment is individualized, and the transition from childhood to adulthood facilities becomes more essential. We still have some unmet needs in the treatment of beta thalassemia. And currently, many novel pharmacological treatment options for beta thalassemia are being tested, and you will hear about them from Professor Katamis and Professor Capellini. The current standard of care remains to be red blood cell transfusion and iron chelation therapy. And I would like to highlight that this is really very important. Safe blood, following the TIF guidelines, good chelation following the TIF guidelines would lead to better survival and a better quality of life until all what is modern and novel would be available to each and every thalassemia patient. There is a great unmet need for therapies that reduce patient reliance on red blood cell transfusions and iron chelation therapy. I just wanted to end with this diagram that summarizes all what I have been talking during this presentation, from the unmet need to the complications. Thank you very much.